This talk is on the basics of ultrasound physics and what we need to know to be able to use the ultrasound machine. There are two main learning objectives of this talk. The first one is to confidently operate the ultrasound machine, and then the second objective is a small degree of ultrasound physics to allow for objective number one. So what is ultrasound? Ultrasound are very high frequency sound waves that are produced from the pulse vibration of piezoelectric crystals. So these are a type of crystal located within the ultrasound probe that vibrates as electricity is applied across it. The same ultrasound beam emits and receives sound waves. So as the electricity is applied across these crystals, a beam is created, it's emitted through the ultrasound probe, there is a pause, and the reflected sound waves are received back. Sound waves, as they come across different tissue interfaces, can either be scattered, absorbed, or reflected. And the greatest reflection and therefore reception of sound waves back at the ultrasound is if the structure is located at 90 degrees to the beam direction. We can see that understanding of the reflection and reception of these ultrasound beams is important when we understand our target trajectory. So in the first diagram to the left, we can see that the image that we are trying to target is running parallel to the skin. So if we hold our probe parallel to the skin, then we get that 90-degree angle between the probe and the target, and we get the maximum reception of those ultrasound beams back to the probe. If we are to hold our ultrasound probe off at an angle, then we can see that we lose some of those ultrasound beams as they are reflected away. Conversely, if we see the second image, we can see that our target is not traveling in parallel to the skin. And so then if we hold our probe in the same position as the first image, where we got the best image, we actually get a weaker image because some of the ultrasound beams are reflected away from the ultrasound probe. It is important to conceptualize the ultrasound beam and how it appears and how it comes out of the end of the ultrasound probe. In the diagram to the left, you can see that the ultrasound beam is a thin vertical sheet of ultrasound that comes out in line with the rectangular image at the base of the probe. It does not take up the whole of the probe, it's a thin sheet of sound, and then we can use that to guide our in-plane and outer plane nerve block techniques. So in the middle image, we can see that if a needle is introduced in plane, it transects the cross-sectional image of the cross-sectional plane of the ultrasound, and we can see the entirety of the needle. In the image to the right, if we use an out-of-plane technique, we can see the ultrasound beam transects the needle, so we have a cross-sectional image of the needle, i.e. a circle. Here we can see the three types of probe in general that are available on each ultrasound machine. So on the left we have linear array probe. This is high frequency, it gives you a very good quality image. The ultrasound beams are parallel to the direction of the probe, and the good quality image comes at the cost of lower penetration. This is in contrast to the curved array probe in the middle. Here we see that the ultrasound beams are divergent from the probe and not parallel. We get very high a high penetration image, so we can image deeper structures. However, the loss is of image quality and of image sharpness, because the frequency of the ultrasound beam is lower. The last type of ultrasound probe that we have is the phased array probe, which comes from a singular focal point and is divergent. This is often used for transthoracic even echoes. In terms of if you can see your target with two with 2 of these types of probes, then you would choose the higher frequency probe to get a better quality image. Here we have the 6 main ultrasound controls that we should be familiar with. They are named slightly different things depending on the make of the ultrasound, but these are the controls that we need to adjust to optimize the image quality that we get. So we'll go through each of these in turn. So with regards to frequency, we saw in the last slide that there are different types of ultrasound probe that have different ranges of frequency, linear being higher, curved array being lower. But within those probes, so if you choose one probe within the same probe, you can make the frequency either higher or lower to make the image more penetrative or of a higher resolution. So you can toggle between a general frequency, which is a mix of the two, a higher resolution image, so that's a higher frequency, or a penetrative image, in which case the frequency is lower. The next control to have a look at and get familiar with is the depth, and this increases the amount of ultrasound beam that is emitted and therefore the amount of tissue that is imaged. And the aim is to adjust the depth so that the target is in the middle of the screen. Now, why this is important is that most ultrasound machines are auto-focused for the center of the screen. So the ultrasound sound is concentrated towards the middle of the image to make that area optimized. And if the image is not in the middle, then the wrong area will be optimized. We can move this focal area from the auto zone of the middle if required. So if you want to see, for example, a vessel in one side and then your target on the other, and you want to keep both sides and you want to keep one area as a better quality, then you can move the focal zone to that alternative area. The next button to be aware of is the gain button. Now, the gain button, it can confuse people, but what it means is the screen brightness. So remember, it's ultrasound. We are dealing with the time and the amount of ultrasound that's reflected. So this increases the brightness of the screen as a whole. If you want to increase the brightness of parts of the screen, for example, you want to increase the brightness of the deeper areas of the image, then you would increase the gain of just some of the image, and that is called time gain compensation. So again, it's screen brightness, but it's not the whole image, it's part of the image. The last ultrasound control to be aware of is the color Doppler. So this shows movement of tissue in living tissue, that will be blood, and we can use that to image blood vessels. We have to be careful that the ultrasound is only as powerful as the image that is created. So if we use lots of pressure and obliterate vessels or obliterate tiny veins, then the color Doppler will not be useful. So here we can see the basic knobs on one particular machine. We look for the depth button, which is usually a toggle button, so we can see that on the upper right of the machine. We click up and down to adjust the depth. The other important buttons are the gain button, which here is B for brightness, CF, which is color flow, M mode, which is the button on the top left. That button is used when using it for an echo. We can also freeze the image. We can see that button even on the bottom right. We can measure, so that's particularly useful if we're using this to image for epidurals or spinals. And then we can flip the image left or right, and those two buttons are located just below the depth button. This image is to show you the the appearance of the time gain compensation. So you can see on this particular machine there are a series of toggle buttons which you can move to the left or right to increase or decrease the screen brightness of the corresponding depth of that part of the image. On newer machines, this may well be touchscreen. In general, it is safer, more effective, and quicker to find and optimize the target image first and then introduce the needle into that image rather than to change the image to optimize the needle visualization. And we will go through tips to increase the visualization of the target on the next slide. However, here, when we're dealing with how to introduce the needle into a fixed image, what we need to do first is to make sure that the probe is anchored, so either to the patient with a steady hand or against something, and then we need to introduce the needle into this fixed image, and we can do that by lining up with the markers that are on all ultrasound probes. So if we are using an in-plane technique, then we'll use the side of the ultrasound probe, and we'll see the middle of that. There is often a marker or an image on the side, and if we introduce our needle in this plane, it will be visualized. For an outer plane technique, we will align the target with the middle of the probe. Again, there's usually a design feature or a mark on the middle of the probe to denote this. And then if you introduce a needle into the middle of the probe, then it will be easily visualized. This paper is a wonderful paper by Mariano and colleagues, which gives us a standardized method for adjusting the ultrasound image if the needle is not fully visualized on the screen. Now, this is the see, tilt, align, and rotate maneuver. The first part of it is to see, so you see where the needle is in relation to the probe. Often this shows that it immediately becomes apparent that you are out of line. The next component is to tilt, and this is to tilt the probe, which is to lean the probe back and forth to optimize the image. The next maneuver is to align. So once you have the correct tilt of the probe and you can see the target adequately, is to then align that image over where the needle is inserted. And then the last part of the maneuver is to rotate, and this is to rotate the distal and the proximal end of the probe around to ensure the whole length of the needle is visualized and you're not transecting the needle. Next, we will go through a series of images and look and see which probes we would use to optimize the image that we have. So in this image, we have an ultrasound image of the wrist. We can see the radial artery, and this image is to look for and to image the radial nerve, which we know is in close proximity to the radial artery. Here we can see the image is poor, and what we would do to increase the quality of this image is to reduce the depth, which would then automatically move the focal zone closer to our target, which would increase the quality of the picture. In this image, we can see that overall the image is bright and there's a very high contrast between the fascial planes. If we reduce the overall gain, we may in fact get more image quality and we may get better delineation of the nerve. In this image, which is an interscalene view, we can see that the target anatomy is very poorly imaged. The first maneuver here would be to reduce the depth, which would then change the focal area to located over the interscalene groove. And then if that doesn't improve the image, then we would increase the gain to increase the brightness and therefore get better delineation of all the nerve roots. In this popliteal nerve block image, we can see a good combination of all the different elements. We can see that the target nerves are in the middle of the screen. There is good screen brightness. It's not too bright, it's not under bright, and because of that, we can see a good delineation of each nerve bundle. So in this supraclavicular image, we can see a dark black structure through the middle of the screen, and it's only by utilizing our color flow that we would see that this is actually a tributary of the subclavian artery, which is going through our plexus there, which would make this block very dangerous to perform at this level. So just to go over our learning points, use the highest frequency probe possible when imaging your target. To use the gain, the depth, the time gain compensation, and the color Doppler, those buttons will make your needling safe, effective, and optimized, and to seek out and read the star visualization technique.